So now we are going to discuss the crush injury and compartment syndrome. Leg crush for few hours in 28-year-old male left unobserved on the ortho ward. Blood, aka urine dipstick blood. A 28-year-old male was found with his leg crushed for a few hours and he was left unobserved on orthopedic ward. Then there is a development of a compartment syndrome with rhabdomyolysis. A patient, John Smith, is brought into A&E emergency having sustained a comminuted fracture of his left tibia and fibula after a stone wall fell on top of his leg. He is complaining of severe pain in his in his calf. So, actually, what could be the possible fate, outcome, complication of his unobserved crushed leg? So, this compartment syndrome and rhabdomyolysis, which can do to it's a double-edged sword. From one side, it will cause hyperkalemia, and from other side, it will cause AKI. So, it will double it will kill the patient straight away. So what is compartment syndrome? Compartment syndrome is a raised pressure in the facial compartment to a level that compromises tissue perfusion. So how you define it? So it's a facial compartment raised pressure to the level where it compromises the blood perfusion or blood compresses the blood vessels. So what are the causes of compartment syndrome? So there are several causes of compartment syndrome, fracture being the most common, 70%, and followed by soft tissue contusion, 23%. Or rather, rare causes include bleeding disorders, including anticoagulation, burns, particularly circumferential third-degree burns, where they form a scar, round a scar around the limbs, or post-ischemia, swelling, reperfusion injury, and tight cast or dressing, and extravasation of intravenous infusion, contrast under pressure, for example, closed limb compartment, and this will raise and lead to compartment syndrome. So fracture being the most common, and the most common fracture is of tibial fractures. So what are the other areas of the body susceptible to compartment syndrome? Abdomen. So there could be abdominal compartment syndrome and upper limb, mainly forearm. What are the clinical pictures of compartment syndrome? So these are 5P. So these are 5P: pain, paresthesia, pallor, paralysis, pulselessness. So this may be out of proportion to injury, severe worsening of pain on passive stretching, and this is the first sign of compartment syndrome. Paresthesia, especially loss of two-point tactile discrimination, indicate limb is salvageable. Pale, dry limb, bluish or black appearance. Paralysis, loss of movement of the affected part due to ischemia to the nerves, and pulselessness, which is the late sign. Pulselessness is the late sign. So normal compartment pressure is 0 to 15 millimeter of Hg. If greater than 30, indication of fasciotomy. Greater than 30 in size. How to diagnose compartment syndrome in a patient with altered sensorium and sensorimotor deficit? So measure multiple site near but not in the fracture site in all compartments of the affected limb. Generally accepted pressure threshold include an absolute pressure greater than or equal to 30 millimeter of Hg, difference diastolic pressure, compartment pressure less than or equal to 30. So these are some ways to measure the compartment pressure. Blood pressure: the lower the systemic pressure, the lower the compartment pressure, that causes a compartment syndrome. So you can calculate the compartment pressure by diastolic pressure minus the compartment pressure. This should be less than 30. Sorry, this less than 30 or equal to 30. And blood pressure: the lower the systemic pressure, the lower the compartment pressure, that causes a compartment syndrome. Means that less pressure will be required to cause the compartment syndrome. So is it necessary? It is necessary, but not in every patient, as compartment syndrome is a clinical diagnosis. Mm, so it's a clinical diagnosis mostly. What will be the treatment? Emergency fasciotomy in lower leg, four compartment fasciotomies through two incisions as an emergency procedures. For example, this is your limb, and you go for medial and lateral incisions. So, incision landmarks, fasciotomy. So, what will you say to the patient when you consent for fasciotomies? So, if the mental status of the patient is all right and he's capable of understanding, then I will explain operation complications, permanent nerve damage, permanent muscle damage, permanent scarring, loss of affected limb, infection, kidney failure, and in rare cases, death can occur. But if the patient is not but if the patient is not mentally aware, then I will go with the signature of two consultants, and I will proceed with it. Why is the patient having AKI? So nephrotic effect of the myoglobin precipitating in renal tubules. It causes ATN, acute tubular necrosis, decreased extracellular volume, vasoconstriction. So the perfusion will be low, kidney perfusion will be low, and renal tubular ischemia and necrosis. They will slough off myoglobin, uric acid, obstructive cast formation in the tubules. So what is myoglobin? So auto binding protein found in the muscles, which is found in cardiac and skeletal muscles. The release of potentially toxic muscle would define rhabdomyolysis. So the breakdown of the muscles and releasing potentially toxic muscle cell components into the systemic circulation. What are the causes of behind rhabdomyolysis? So blunt trauma, skeletal muscle crush injury, massive burns, hypothermia, hyperthermia, ischemic reperfusion injury. Ischemic reperfusion injury claimed on the artery during surgery. For example, you have claimed the artery during surgery and it goes beyond 6 hours up to 12 hours. This will cause reperfusion injury. Prolonged immobilization on a hot surface, for example, an alcoholic or a druggie sleeping on a bench the whole night, so it will lead strenuous and prolonged spontaneous exercise, marathon running, they have rhabdomyolysis, or beating someone. So they will have, for example, in the prisoners, they have usually this AKI because of the rhabdomyolysis, because of the beat up session. Statins, fibrates, and alcoholic, they also cause rhabdomyolysis. What would be expected laboratory findings are for rhabdomyolysis? What are the electrolyte disturbances in rhabdomyolysis? So laboratory finding and rhabdomyolysis and electrolyte disturbance in rhabdomyolysis are the increased creatinine kinase CK will be greater than 5 times of the normal, increased lactate DH creatinine, electrolyte hyperkalemia, and metabolic acidosis will increase anion gap, hypocalcemia, hyperphosphatemia, hyperuricemia, myoglobinuriria suggested by a positive dipstick in blood to blood in the absence of hemoglobinuria. Red cells on microscopy. How will you manage the patient? I will manage the patient according to CREST protocol in ABCDE manner. And first thing first, I will do fluid resuscitation, ensure good hydration to support urine output greater than 300 ml per hour, using IV crystallide until myoglobinuria has ceased. Diuresis mannitol may be used, alkalization of urine, sodium bicarbonate to prevent renal damage. Treat electrolyte disturbance, hyperkalemia, treat it, monitor ECG electrolytes, urine output CK 6 to 12 hour, LDH urine, myoglobin, and compartment pressure as well. What is reperfusion injury? So revascularization of ischemic areas causes washout of old metabolites from that area to systemic circulation, and there is a high response to this. So this can cause reperfusion injury. How alkalinization by sodium bicarbonate prevent renal damage? So actually, uh, um, it will um, it will increase pH of urine, subsequently prevent formation of toxic myoglobin cast in acidic urine. It will shift the potassium from extracellular fluid to intracellular fluid. It will enhance urine excretion of excess potassium. So what sodium bicarbonate do? Sodium bicarbonate do for numerous of things. For example, for example, first of all, it will change the pH. It will increase the pH. So usually myoglobin casts are formed in acidic. So it will prevent this. Plus, it will cause the secretion of potassium, excess potassium, and it will also shift the potassium from extracellular fluid to intracellular fluid. So this is all about the compartment syndrome. Okay, so here we will look at the uh, here we will look at the reperfusion injury again. Uh, so reperfusion injury is tissue damage caused by restoration of blood flow after ischemia due to reactive oxygen species generation, calcium overload, inflammation, and mitochondrial dysfunction. So this is the proper definition of a reperfusion injury. Once again, I will repeat that reperfusion injury is the tissue damage. So what is basically it is the tissue damage caused by restoration of blood flow after ischemia due to generation. Okay, so this is tissue damage caused by um, restoration of blood flow after a period of ischemia. Why? Because of generation of reactive oxygen species, calcium overload, inflammation, and mitochondrial dysfunction. So this is called reperfusion injury.